and I hope I close it fast and within time. The most important part is the postpartum, because it has been seen, though we have come to a maternal mortality rate of 88, 50 to 70% of mortality takes place in the postpartum, and of which 45% tends to take place within 24 hours and 2/3 between 1 week. So the red flag signs are not just for the obstetricians on the floor, it is also for the patient who is being discharged, for the family who is being taking care of the woman, and all the ASHA workers in the periphery who are going to be taking. So when we talk of the red flag signs in the postpartum, they're both physical as well as psychological. So among the physical, we need to train them when they're being discharged of heavy bleeding, which means soaking more than one pad, passing clots of the size of a golf, having fever, foul-smelling discharge, mastitis, discharge from the cesarean sign. Even if the legs are swollen, they tend to think it's just part of the pregnancy, but if a single leg is swollen, it's hard, they need to come to us, or if they have severe headache and the blurred vision. So coming to the first main cause, and that's the postpartum hemorrhage. Dr. Poonam has spoken about it very vividly and strongly, but what I would say that it still constitutes the major cause of the death, and it is about 27% of all the maternal mortalities because of the postpartum hemorrhage. And the definition I'm going to re-highlight for those who have not been there for Dr. Poonam's lecture, it has changed. The quantity of blood is important, but more important is the warning signs that is there. So if the blood loss is more than 300 and they have warning signs, it is to be considered as a PPH, and the same is by the FOGC as well as the maternal health. So we are looking for the quantity of the blood loss, but more importantly, we are looking for the warning signs in the mother. We all know that estimation of the blood loss is always inaccurate. We tend to underestimate. So that is why the importance comes to measuring the signs. The rule of 30 is an extremely simple one. If the systolic blood pressure falls by 30, if the heart rate increases by 30, if the respiratory rate is more than 30, if the urine output is less than 30 and the HCT has fallen less than 30, she has lost 30% of the blood volume and she needs resuscitation. The second thing that emphasis has been laid by FIGO also and by each one of us is the shock index. It's a simple thing that can be calculated by your mobiles. That is the heart rate by the systolic blood pressure. Anything above 1, your tentacles have to be raised and you need to get into action. It determines not only the maternal mortality rate but also the number of blood transfusions that a woman would require. Coming to the sepsis, we never have ever regarded sepsis as a major cause of maternal mortality, but if you look at this, it constitutes the second most common cause of maternal mortality, and it is associated with organ dysfunction. Nearly 16.5 per 100,000 live births are because of the sepsis. So the red flags of sepsis is fever. We tend to just rule out the fever, but if there's fever more than 38 persistently and it is found to be high, any foul-smelling discharge, if there's been found in this case a tachycardia or rapid breathing and an altered consciousness, we need to be really going into the action. Always look for the signs, that is a tender uterus, foul-smelling discharge. If you're having that, there's any breastitis which has been present, any pus or discharge, this should tell us that yes, she could have the sepsis. So RCUG had come out with a term called think sepsis, when they had found that the maternal mortality had increased because of sepsis. So that is what we also need to adopt. Think sepsis wherever there's fever, wherever there's tenderness of the uterus, a foul-smelling discharge, any discharge from the stitch line. We have to start thinking about sepsis just as we think about the postpartum hemorrhage. The third thing we're talking about is the postpartum collapse. Collapse is a sudden thing which may be very difficult for us to actually have the red flags. We know there are the 4H, the 4Ts and the E, and there's an mnemonic which has been said, which is the heparin, which can rule out all the causes, but most important for us is to detect if this patient is going to land up in a collapse. And when the patient is admitted in the hospital, every nursing home should have this modified early obstetric warning system chart. It's a color-coded chart from green to yellow to red, and this is what can save a patient from landing up in a postpartum collapse. So there are various protocols, the green pathway, the amber and the red. This is from the UK, but we need to make in our hospitals our own pathways. So if we get a single one in red, or if we give a Mu score between 5 to 6, we need to swing into action. We need to monitor this patient more frequently. We need to get her into the HDU so that we do not land up with the maternal collapse. And if unfortunately we should be pressing the code blue. Coming to the eclampsia, we know that everyone is adept at managing the antepartum eclampsia, but postpartum eclampsia is something that we do not lay much emphasis on. So in spite of the fact that we are monitoring the patient, any patient who's at high risk, who's had antenatal eclampsia or PET, she should be sent home with the warning that if you do have a blood pressure more than 140/90 or if above 160/100, any headache, any blurring of visions, you need to contact your healthcare provider or reach the hospital. As far as the DVT is concerned, I'm sure every obstetrician who has been working for quite some time must have seen 2 to 3 cases of DVT in their career. Although we say that in India the incidence is less, but it is one of the major causes of deaths. So if the patient comes to you with swelling, which is specifically in one leg, it is hard, it's hot, there's a hormone sign, it is tender to touch, think of DVT. And the important reason that we need to think and evaluate is that it is a cause of pulmonary embolism. So if a patient with such comes with shortness of breath, she has a severe chest pain, there is tachycardia, there's coughing up of blood, which means a pulmonary edema, she's suddenly feeling very light and dizzy, and she has got a leg which is swollen, we have to think of DVT and get into action immediately. The last is the mental health, and this is where I want each one of us to really focus. Physical signs we can see, but the mental signs we need to evaluate. And we need to understand that postpartum depression is an important cause in 14 to 34% of women, and it is becoming a cause of maternal death. So we need to educate every woman who's being sent home, all the family over there, that if a woman is feeling very low, she feels disinterested, she's anxious, she's not taking care of the baby, she's not dressing up well, she gets feelings of harming the baby or herself, she needs immediately to talk to her husband. The husband needs to contact the obstetrician, any healthcare provider, because no woman should die because of postpartum depression and committing suicide. So I would say over here that in the postpartum period is where we need to work. If you really want to bring down a maternal mortality rate, our focus has to be in the postpartum period. We have to recognize the red flags. Just delivering a baby is not our job. Our job is to take care of the woman for the first 42 days and then to prevent any NCDs that take place later. So prompt treatment, early recognition is what in the postpartum can reduce the maternal mortality rate. Thank you so much.